Welcome fellow colleagues. Over the next 5 minutes I will present the clinical implications of diurnal variation of intraocular pressure. Diurnal fluctuation of intraocular pressure has been observed for many years. It's been over 4 decades since Drance studied this variation over the 24-hour cycle. He found on average that normal eyes had variations in the range of 4 mm of mercury, whereas glaucomatous eyes had a variation in the range of 11 mm of mercury. So why are these fluctuations of intraocular pressure important to us as practicing ophthalmologists? The problem is that intraocular pressure, which we measure during office hours, is only a snapshot over seconds. This leaves 86,000 seconds that we are not measuring. In other words, the intraocular pressure that we measure may not be a true indication of the rest of the day. We have all managed patients with apparently stable intraocular pressures who have progressive field loss. We tend to diagnose these patients as normal tension glaucoma. In fact, these patients may be found to have fluctuating intraocular pressure if diurnal phasing is performed. The study by Hughes et al. In 2003 demonstrated this phenomenon. They studied glaucoma patients with progressive field loss. Despite having good intraocular pressure control, they had an average diurnal peak of 6 mm of mercury, higher than the average intraocular pressures. For instance, a patient measured in the clinic with an intraocular pressure of 14 may well have intraocular pressures peaking over 20. Ezrani et al. In 2000 proposed that diurnal variation is an independent risk factor for glaucoma progression, not just absolute intraocular pressure. But fluctuation is not a factor commonly measured in clinical practice. Weinrep and colleagues from San Diego have studied diurnal variation in their specially designed sleep laboratory. They have measured the variation in many normal and glaucoma patients for a range of different ages. They regard intraocular pressure as a dynamic physiological parameter which can change from moment to moment. When subjects were measured in the supine position at night, they found intraocular pressures were higher than daytime mean intraocular pressures. This is an important finding as 1/3 of our lives is spent sleeping. Normal patients tend to peak in the morning at around 5:30 am to 7 am, whereas glaucoma patients peak around 7:30 am to 9:30 am. This may be an important consideration, especially when reviewing glaucoma patients at different times of the day. Weinrep has also suggested that for measurements made in the office, a supine intraocular pressure measurement may be a better predictor of peak intraocular pressures than a sitting measurement. This measuring of pressure in both a sitting and supine position is not common practice. Many studies have been published in the last decade to assist us in the management of glaucoma. These studies have indicated that intraocular pressure lowering is currently the best option to slow the progression of glaucomatous field loss. So what can you do in practical terms to monitor diurnal fluctuations? I find recording the time of day when an intraocular pressure is measured to be one simple way of monitoring the fluctuation. You may also consider bringing patients back at different times of the day. Occasionally phasing may be required in those patients in whom the intraocular pressure is apparently stable but the field loss is progressing. This can be done within office hours by asking the patient to come at the opening of the clinic and measuring the intraocular pressure every 2 hours until the end of the clinic day. If a more formal measurement is indicated, then the patient can be admitted to a hospital for 24-hour monitoring. These measurements can be performed by trained clinical nurses via Goldman applanation tonometry or tono pen. In the future, home monitoring devices, contact and even intraocular devices for measuring intraocular pressure will become more readily available. A major factor in choosing a glaucoma medication is its efficacy in lowering the intraocular pressure. Of increasing importance is the ability of the drug to keep lower intraocular pressure as stable as possible through the 24-hour cycle. Beta blocker type medications such as timolol have been found to have good effect during the day but poor control through the night. Newer agents such as Prostaglandin Analogues have been found to be more consistent control. Not all patients respond to medications in a similar fashion. It is our responsibility as their treating physician to choose a medication that is optimal for a particular patient. The prostaglandin analogues have the convenience of once-a-day dosing and have been found to stabilise the diurnal variation. They differ, however, in their potency and receptor affinities. We should consider such data critically for every individual patient to determine where each prostaglandin analogue fits into their overall treatment regimen. Indeed, if medications are not successful at stabilising the visual field, then filtration surgery needs consideration. Filtration surgery acts as a high-pressure outlet valve and has been demonstrated to lower intraocular pressure and smooth diurnal fluctuations. Glaucoma is a lifelong disease. Our goal must be to maintain useful vision over the entire lifetime of the patient. As such, we need to adequately control as many of the risk factors for progression as possible. This now includes diurnal variation of the intraocular pressure. Thank you very much.